It's your world. 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 Broadway. Saarah Dash. It's your world. It's your world. It's your world. Saarah Dash.
Hi everyone, it's your girl Saarah Dash from Atlanta, Georgia, hosting out of Status Network TV. Today we have with us our guest Marilyn Dillard, Dr. Marilyn Dillard, which we would like to introduce to you. But before we get started, we just want to let you know that if you like our vibe, please subscribe to Status Network or Manifest TV on Roku, Apple, and you will find us on Facebook streaming, also on YouTube. So this is our first show, and this show was created to be able to educate the melanated people and to bring us to a higher perspective. So today we will be brought to a higher perspective with our guest, Dr. Marilyn Dillard, who is going to speak to us today about the science of COVID-19. So listen up, call your family and friends, because I think there's plenty you'll need to know today. So, Dr. Dillard, we're getting acclimated to all of this. However, we'll go ahead and introduce Dr. Dillard. And Dr. Dillard actually comes to us from the Seton Hall Law School, the Bates College of Engineering, Washington University of Health Sciences, Dartmouth College, Tuck School of Business. He has been a medical practitioner for 7.5 years. He's conducted 2 years of medical research of rhythmogenesis of inhibitory synapses. His mission work includes the creation of 5 healthcare clinics in rural Columbia with the Seattle Rotary Club. He is also the CEO of the nonprofit organization Institute for Progressive Sustainable Development. He's a board member of the President's Council of Economic Development of Sierra Leone and also serves as the economic consultant to the Ambassador of Sierra Leone. His hobbies are inclusive of golf, flying, chess, and physical fitness. So thank you so much for joining. It's your world, and we appreciate you investing in our vision and coming on the show as a guest. So today we want to be able to talk to our guests about COVID-19 and the science of COVID-19. And there are a lot of questions that everyone has. And of course, we've been inundated in the news with various things that's been going on where COVID-19 originated. You know, we've gone through the whole walk of quarantine. I don't want to go repeat the diatribe because right now we're in the phase of vaccines. But even before we get started with that, we want you to be able to give us a little bit about yourself and tell us what it is you're working on so that everyone else will know what it is that you do besides being a medical practitioner.
Thank you for having me, Sarah. Currently, I've recently started a nonprofit, the Institute for Progressive Sustainable Development, and we actually work with the U.S. government and some private donors and 1,000 of the Fortune 1,000 corporations. And the goal is to get African Americans to invest in Africa, specifically starting with Sierra Leone. And the way we work with the 1,000 corporations is we're trying to get the 1,000 corporations to actually assign some of their employees, African American employees, to go into Africa and expand their businesses on the African continent, starting in Sierra Leone. And we work with the United States government for funding and for the United Nations and the Department of Commerce and the Department of State, as well as the Sierra Leone government.
Okay.
So that's what we currently do. And currently we do work there in the medical facilities. We establish in medical clinics. In the rural areas, currently right now we're doing it in the mining districts. There's 2 mining provinces that we're working in there. And we're also trying to get mining companies in America to go and invest in Sierra Leone. Right now, the Chinese is actually taking over all of the mining, and they have established what they call a debt trap,
Okay.
where they getting African governments in debt, and then they're infiltrating the continent with Chinese. So pretty soon the African continent, the citizens in Africa is going to be second-class citizens to the Chinese. Chinese is going to be the dominant culture in the country.
Absolutely.
So we're trying to.
I've certainly seen that even in even in the West Indies. I'm originally from Jamaica, and we have certainly seen that same trend across the West Indies as well. But thank you for that information. That's very impressive, and we hope that we'll be able to help. As you stated, they're looking for people to bring businesses, so hopefully a lot of people will listen and understand that there are opportunities beyond the United States of America into the African diaspora.
And our website is ipsd-institute.org.
IPSD Institute.
IPSD-institute.org.
Okay.
If you can go there.
There you go, folks. If you want to be able to get some information on Dr. Dillard and some of the initiatives that he's working on, please feel free to go to his site. And please repeat that again.
The site is IPSD-institute.org.
All righty. Thank you for that. So we appreciate you definitely briefing us on those initiatives. And are they going to be? How will they actually recruit African Americans from America to be able to take? Is there a strategy? Take their businesses to the diaspora?
Well, the corporations will select a number of their current employees who's working in the current offices in the United States. Like IBM will select about 5 to 10 employees. They would send those employees to Sierra Leone, establishes IBM offices, work with a Sierra Leone native, and teach them the business of IBM, how it's run in America. And then they also bring that Sierra Leone business owner back to America. He works in the IBM, and they teach and they train them American business principles and American business culture, so that he can run his business that way, and it helps to expand IBM throughout the African continent.
Okay.
And the people who actually work for IBM, they don't have to pay their airfare to get there.
That sounds like a good deal.
Yeah,
well, we certainly would like to continue that conversation some more later on, because I'm sure there are many people out there, people that I've spoken to who have lucrative businesses or are just starting businesses who may be interested in taking their businesses to the diaspora. So certainly we can actually come back in a further date and speak to the public regarding that, because there are many contractors out there who are looking to expand beyond the United States. So thank you for that information. Today we wanted to focus on the subject of COVID-19 and the science of COVID-19. You know, I don't want to exacerbate people with all the numbers and just continue speaking about the things that we already know. There are things that we don't know. There are things that we need to know. And I don't hear those things in those conversations. In addition to the fact that we, as melanated people, and you can, classify that as blacks and Latinos or anyone who falls into the minority sector, but reaching out to melanated people to understand really what COVID is. We've seen what it does, but we need to understand what it is, and we need to understand how it is going to impact our environment from here on, until. So one of the things I wanted to know, and that I've been hearing questions about, are things like, what are some of the side effects that should be anticipated with the COVID-19 vaccine? I think people are very afraid because, we assumed that the vaccine was going to be safe, and then we saw on the news where people were dying from obtaining the vaccine. So what side effects should we anticipate after receiving COVID-19 vaccine?
Well, first, the vaccine is very, very safe. We have the 3 vaccines that we currently use here in the U.S., which is the Moderna vaccine, the Pfizer vaccine, and the Johnson & Johnson vaccine. So the efficacy of those vaccines are very, very safe. Some of the side effects that people are experiencing, not very many with the J&J vaccine, the Johnson & Johnson, but with Moderna and Pfizer, they're experiencing more of pain at the injection site, and there's redness and swelling at the injection site, and you have muscle aches, and then you have soreness, and then pain in the joint pain. And so those are the.
Was that Johnson & Johnson? Didn't they go on pause because the vaccine demonstrated or showed that patients were suffering from thrombolytic
But Johnson & Johnson, I think, was blood clots.
Yeah, they were suffering from blood clots.
Right, yeah, with Johnson & Johnson. But it's the same symptoms as with the flu, basically, from the Moderna and the Moderna and the Pfizer. With Johnson & Johnson, you don't experience those symptoms. Johnson & Johnson had the blood clotting issue, and that's why they put it on temporary hold for a couple of weeks, I think.
Okay.
Yeah, but
And
those
what
side
happened
effects.
in those couple weeks?
So those they really reinstituted the J&J vaccine, but even the side effects with the Moderna and Pfizer lasts for maybe 14 days, and after that you're fine. With the J&J vaccine, most people did not experience any side effects. I think they might have had a few headaches, but that was it. There was minor headaches.
Okay, so I have friends and family who have received the vaccine and ended up in the hospital. I have a cousin right now who's in the hospital who took the vaccine, so did his wife. And both of them, she didn't become ill, but he became very ill. And that's probably because, he has an underlying condition of diabetes. Is it that if you have other underlying conditions that it will exacerbate, the experiencing those symptoms?
That's possible with any vaccine. If you have some underlying conditions, that it could affect the how the vaccine reacts with the human body. Mm-hmm. And so it's like everything. It's like with the Moderna vaccines, it's 95% efficacy. The Pfizer is 96%. And the J&J is around 50%.
If you don't mind me asking, what's those variations?
Yeah, so what that means is that 3%, like if you got 96% efficacy or efficiency, then you figure 4% of the people, the vaccine is not going to be effective at all.
Got it.
Okay, and so if you're looking at 1 million people, that's almost 400,000.
That's a lot of people. If you're looking at it from that scale.
There
right?
is, yeah. And so that's the differences in those. That's what those percentages mean.
So
when you hear someone, I'm sorry, but so when you hear someone says, "Oh, I had the vaccine," like currently the New York Yankees had 8 baseball players who had taken the vaccine, but they still got the COVID virus. Mm-hmm. Okay, and so that's because of that percentage difference. Now, even when you get the COVID virus, doesn't necessarily mean that you're going to have the complications and you're going to have respiratory issues. It just means that you get the antibodies in your bloodstream. Okay. And so when you do the blood test, the COVID test, those antibodies, the COVID virus is going to show in the bloodstream, but it's not going to affect that person's health because they have the vaccine. So don't be afraid if someone says, "I had the vaccine and I still caught the COVID." That just means that the COVID virus is in the bloodstream, but the COVID virus is not affecting that lung, what it's causing respiratory problems or blood clotting.
Okay. What about people who are breastfeeding, who are nursing or pregnant? Should they submit to a vaccination?
Well, the American College of OBGYN has recommended that if you're pregnant, you should get the vaccine. Okay, there is no tests have been done on individuals who are pregnant or in experiencing pregnancy. So at this point, they're scheduled to do trials, but they haven't did any trials. But according to the American College of Obstetrics and Gynecology, they recommend that if you can get the vaccine and you're pregnant, that you should. So it's going to be a personal choice, and one where you probably more or less want to talk to your OBGYN before you take the vaccine.
But if you haven't had trials on a woman carrying a baby that has a vaccine, it would be counterproductive to talk to the OBGYN because he has no data to make a comparison to say, well, hey, based on such percentage, this is the risk. He can't even adequately advise a person because there is no data to support that. So I'm just really just thinking, I know it's probably, medically, there's some thresholds that you can't cross, but as a patient, I'm thinking, well, if I'm pregnant and I'm breastfeeding and there's no data to support if it's safe, then why would I, want to do it? So, I guess it's just up to everyone to make sure they have as much information as they make to make an informed decision. But
Well,
that
would
just
come
seems
from-
counterproductive.
Yeah, that would come, you have to talk to your OB doctor. But basically, it's assessed where, because we know what the underlying conditions are that cause COVID to become exacerbated. So, and we know that if I'm seeing a pregnant, well, I don't do maternal health, but I'm assuming if I did, and I had a patient that didn't exhibit any underlying conditions, then I would feel safe recommending it, because the way the trials were done in all three of the vaccines, it was like, I think Pfizer had over 40,000 people, Moderna was at 30,000, and it was a really diverse group. But of course pregnancy wasn't included. But it was through a diverse group of individuals, and from that, from those trials, they realized that what the conditions were that would be prohibited to use the vaccine. And so if I had someone that was just normal, had none of the underlying conditions, I would recommend that they would use it.
So what about if they've already had COVID? If they've already had COVID, should they get the vaccine? And if so, what would be the benefit or risks thereof?
If they already had COVID and they had gotten over the virus, they had returned to their normal duties, being able to work, being able to sleep well, being able to go to work, to go to school, and without having any problems, then I would recommend that they get the virus. If they are experiencing complications doing any of those normal activities that we would normally do, then I would recommend that they wait until those symptoms subside before they take the vaccine.
Wow. Okay. So let's say that, so one thing that concerned me, and I'm sure a lot of others, is the rapidity in which the vaccine was developed. I don't think there's any vaccine in the history of vaccination that has been developed in such record time. And how can we depend on the information that it's safe when it's been developed in such record time? I mean, it typically takes how many years to develop a vaccine? 5 to 7 years?
Actually, it takes about the longest recorded is like 28 years for developing a vaccine, and on the human papillomavirus, it took 15 years before they could actually do all the research and still develop the vaccine. And I think before the COVID vaccine, I think it was the polio vaccine by Dr. Jonas Salk that actually took about 4 years to develop that vaccine. So the COVID vaccine was developed in less than 11 months. Okay, and so because you have all that data and you know that these vaccines it normally takes it from 4 years up to 28 years to develop the vaccine. So now someone's asking you to take a vaccine that's been developed in 11 months. Okay, and so there is a reason for concern. Okay, but to explain that, this is what the difference is. The COVID vaccine, the COVID virus is what you call an mRNA virus, okay, in which uses and it's kind of getting kind of medicinal, and I try to keep it simple. So on like polio virus and human papillomavirus, some cancer cells, what you have is a protein, okay? And so you would take the virus itself, and you would take the protein from that virus, then you got to take the protein, you got to put it in eggs, or you put it in a cell, and then you have to wait months for it to grow.
Right.
I mean, once it grows, then now you can start doing research on it. Then you gather in your research group and the individuals that you're going to use in the research. And so all of those things take years normally. So the COVID virus is different because with the COVID, you have the spike protein that's on the COVID virus. That's why they call it
Those
corona.
little things that stick up like a bump.
Exactly, and that's why they call it the coronavirus, because it's like a crown that sits on your head, you know?
I was wondering, what is
Yeah.
the corona and the virus, and what's the difference? Like,
Well,
what,
I think
what
corona
initiated
in
the actual
Spanish
name?
is crown.
Crown,
and
it is,
it's
right.
corona, yeah. And so that's why.
They kept showing the bear, so one couldn't tell.
Right, yeah. So that's why they call it coronavirus. So anyway, those spikes in the crown, the king's crown, the queen's crown, those spikes is, they've got glycoproteins, and those spikes are the ones that penetrate the human cell and actually infect you with the virus. So because they already have that protein, they don't have to create the protein. So they knocked off years of creating the vaccine to treat the virus.
Okay.
Yeah. So then what they do is they just take this spike protein that they have from it's called a glycoprotein that they take from the coronavirus, and then they just create RNA from it. And the RNA is a lot more simple than creating a protein vaccine. So what you have is an mRNA vaccine, and it's easier, more sooner to manufacture that.
So when did they develop this technology? How comes they never utilized this technology previously to,
Well, it's not that many viruses been identified with a glycoprotein.
Okay.
Yeah, you normally have to go inside the virus and pull out the protein.
Okay.
But the good thing about the coronavirus is it's on the outside of the virus itself, the cell, and so you can easily get there. And from there, you just create mRNA.
Now, so why are they causing blood clots?
The blood clots are caused because in the Johnson & Johnson vaccine, where they really experienced blood clots, I think they first started in India and then in Europe, and then a couple of people developed blood clots in the U.S. So the blood clots, some people are susceptible to blood clots, and other people are not susceptible to blood clots. So what happens is when you're being treated for the virus, and there is underlying conditions like obesity, diabetes, those things could cause blood clots, and especially with obese people. So if you, once you get the virus and you go home for 14 days, or you're in the hospital, you're kind of immobile. You're not moving around, and you're not, you're just not active. So you're more susceptible to clotting. Okay, and so what they're doing now is they actually take a blood test. When you go in for the COVID virus, you get a blood test, and it actually, from the blood test, we're able to determine will your blood clot and how soon it will clot.
Right.
And if it's determined that your blood would clot within 4 seconds, it's normally most people's blood clot in about 120 seconds. So if your blood clotting within 4 seconds, 40 seconds, so what they would do is say, well, this person needs a blood thinner.
Okay.
So they treat you with a blood thinner. And if your blood, your what they call PPT, prothrombin type, if that blood clots, if it's just normal, like 120 seconds, 90 seconds, 120 seconds of blood clot, then they just give you like the compression stockings.
Okay.
To keep you from creating, if it's normal and you're using compression stockings in the hospital and being more mobile, walking around, then they won't really use the blood thinner.
Okay.
So, yeah. So it's the blood test that's
Are
critical.
using aspirin safe as well?
Well, it depends, because if you're a clotting person and you're using, if you clot easily, or your PPT time is, like within 40 seconds, then aspirin would help you. Okay, and if your PPT time is just regular 190 to 120, then if you're using aspirins, then your blood is really, really thin. So then if you become a surgery patient,
Then it's a risk.
then yeah, it's a risk because you can bleed out during surgery.
hemorrhage.
Right. Yeah.
Wow.
And so that's why they're doing the blood test now when you go in for the COVID conditions.
What about exercising? I mean, are people allowed to exercise if they've received the vaccine or if they've had COVID? I mean, I've had people that's, sent us questions asking us about exercise and, does that actually help build the immune system to better defend yourself off from the virus? How does exercise impact or benefit or not at all?
Well, I wouldn't recommend exercising if you had COVID or you experiencing COVID symptoms. A lot of patients want to know how they can get back, how soon they can get back into the gym or to working out, and it's when the symptoms have abated. But even though the symptoms is abating, you're feeling normal. You're going to work, you're sleeping well, you're waking up. You're going to school, and you're taking care of the kids, and you're feeling normal. You still don't rush into the gym and go back to the peak that you were exercising at. So you gradually build up to that, because even though you're not experiencing symptoms, the symptoms could still be there. And so if you go into the gym and you start trying to exercise back at the peak where you were before you got the virus, you could actually cause more damage to your respiratory system. Okay. And so I recommend that you just go and you build up gradually, and till you get back to where you're at, and then continue your exercise.
Okay. So another question that I had was, or concern, I guess you could say, is about travel. Of course, travel is limited in some areas, restricted, and in some areas it's open to travel. When people are traveling, internationally as opposed to locally, they're required to get, tests. Those are the requirements to come into the country. Is there a way to bypass those tests? Because some people just don't want to test. They don't want to expose themselves to any of what they may feel is part of a conspiracy to inject DNA particles into your bloodstream. So is there a way to get around the test? I know it sounds pretty ridiculous, but everybody has their concerns and they're legitimate.
Well, if you're traveling, I've traveled a lot during the COVID, having to travel for a business reasons. And so I used what I could just call good medical sense. But before I get into that, since you mentioned the word conspiracy, I'd like to just talk about that just for a second.
Absolutely, okay. Please.
So I hear a lot of people telling me about why they don't take the vaccine and why they feel that it's unsafe, and they have all these theories about it. And what I like to tell people is the person that told you or where you read about the conspiracy or the Bill Gates are putting in nano chips in to track you, things like that. So the person who told you that, the first thing you need to ask yourself when someone tells you something you do not believe is, the top of the line, the top of the food chain in this COVID virus science is a medical doctor. And so if someone is not providing you the facts from a medical doctor, then they're not facts. They're just theories. And you can't operate on those theories because it'll cause you more harm than good. So a lot of people, and especially in our community, don't have a private physician. And a lot of people they might visit the doctor once a year, if that. Right. And so they have no way to get that information from their private physician. So they take information from the next door neighbor and from Ms. Mary that works down at the corner store. And so I just wanted to say is like just going forward, ask yourself, the person that's providing you the information, are they a professional person, and is that information that they just dreamed up when they was laying in bed or someone told them that? So I recommend going and educating yourself and looking in medical journals, the New England Journal of Medicine. You can find some articles on the internet. And you read those articles because those are the medical professionals who actually knows all the science about the virus. And you don't have to worry about those conspiracy theories, and actually those theories are going to stop you from being a healthy person and possibly even cause you your death. So I just wanted to say that. And then your question to me was about the that you wanted me to answer? What was it?
Which one is it about? Well, actually, you just answered the question.
Okay.
Yeah, you just answered the question. And, well, it was about travel, about people.
Oh yeah,
getting,
travel,
vaccines,
travel.
about
Yeah, so
but-
travel. Yeah, so I travel a lot throughout COVID. Travel on an airplane, it's the air is filtered out in an airplane about 95 times an hour. Okay, so if we're going to have COVID virus droplets in the air, the airliner, the filter's just going to pull that out. Okay, because the air is changing that often.
Okay.
On a flight.
So you're saying it wouldn't be necessary to wear your mask on the plane because it's continuously filtrating?
It would be necessary because you're sitting so close to someone, and as they speak, the droplets come out.
Droplets are coming out.
Before they can filter into the air. They're right in your face, and you can breathe them in. So that's why I would wear the mask. And then some people are asymptomatic on the plane, and you may even be asymptomatic, if you're the passenger, and so you don't want to put the droplets out there if you don't,
Okay.
So the mask is essential. I would always recommend wearing the mask on a plane. Even today, when they say do not wear masks, we don't have to wear masks anymore. I feel that you should, if it's not inconveniencing you, or if it's not uncomfortable, then you should wear the mask.
So that brings me to that question with the CDC's guidelines on not having to wear the mask if you've been vaccinated. You can now relax these rules. I mean, after we went through all of this of getting people to wear a mask, and now we're telling them to roll back the mask. You just stated that you would still wear a mask, but if a person has the vaccine, do you feel it's necessary for them at this point to still wear a mask?
I would think until we reach herd immunity, that you should wear the mask. The mask, so whether to wear the mask or not to wear the mask, is such a political thing that started in the last administration that it seems to, there's so much political pressure right now, I feel, on the medical and healthcare professionals who's working in the White House, Dr. Fauci and et cetera, that they are not able to actually give the best medical advice about the mask. It's just too much, it's just too political at this point.
Okay.
And this is uncomfortable. You got the vaccine, but my thing is that until we reach herd immunity, you wear the mask. Even though you can go to places that take the mask off. If you're outdoors and not around people, you can take the mask off. But I wear if I'm outdoors taking a walk, I have my mask around my neck. Excuse me. But if I'm gonna pass another person, I'll pull it back over.
Okay.
But then the mask is not uncomfortable to me.
Right.
And I realize that the mask protects our community.
Okay.
Even though you may not have it, and someone's grandmother you passes by on the street may not have it, and you can give it to them, or you might be asymptomatic. And so the mask is not about you; it's about your community.
Right.
So if you look
Absolutely.
at it that way, yeah.
Absolutely. Well, we definitely appreciate your responses regarding that. I wanted to pivot to another subject, and the reason that I wanted to pivot to this subject is because even though it is actually around racism in healthcare, and even though we're talking about COVID, it appears that there was a lot of, well, not just a lot of, it's been around for a long time, but it became a little bit more inherent when COVID-19, emerged, and racism and how it emerged. I mean, we saw evidence of that with all the things that, have gone on for the past year. And so even at that period where people were going to the hospitals or interacting with healthcare professionals, there were reported incidents, and probably more so because of COVID, regarding their interaction with healthcare professionals. So we just wanted to pivot on that, because in COVID-19, there's been a lot of mismanagement, even around coordination of care. And by coordination of care, what I mean to the public is that if a loved one goes into the hospital, you hear nothing more of them. It's very hard to speak to a healthcare professional. It's very hard to coordinate care. It's very hard to obtain information because people are not following due diligence by ensuring that their family has adequate documentation to protect themselves when you need someone to speak on your behalf. And so I've even encountered that my interaction with healthcare professionals, and racism doesn't necessarily mean black or white. There's racism between blacks. So as a provider, I just wanted for you to pivot to that subject, because a lot of that has become inherent during COVID-19, because we've had a lot more interaction with healthcare professionals. Do you feel that there's racism in healthcare?
Oh, absolutely. Racism in healthcare goes all the way back into probably pretty much to the beginning of slavery. The slave masters used to inflict quite a lot of pain on the slave, and because he put the pain on the slave, sometimes the slave could endure the pain. It led him to believe that the black skin was thicker, our nerve endings were, we had less nerve endings in our skin than whites did, because there was even one incident where they cut off a slave's arm, cut off his arm at his elbow, and held it up, and the slave was sitting in a chair and was smiling like he never really felt that. And so that has passed down through the medical community. And so in most medical schools, you're taught that blacks can endure more pain than whites. And so when the white doctor leaves and starts working in the field, those thoughts that he brings out of that school is actually utilized during his treatment for African Americans. And so that is the beginning of the racism. Racism is just permeates the healthcare system and the way it's used. If people with less money are given the same medicines but less amounts of the medicine. A good example of that would be on your like the flu. Some people catch the flu. If you have good health insurance, you can go and first thing we do is look to see what kind of healthcare insurance you have. If you're on Medicare, if you got Humana, or if you got Kaiser Permanente, if you get really, really good healthcare insurance, then I can prescribe you a Z-Pack, which you're going to take 5 pills in 3 days, and you're going to be back at work. If your socioeconomic status is bordering right into poverty, and you're on those social programs or government programs, I'm going to give you a 10-day treatment, which you're going to have to take the same pill 4 times a day, which most people can't do that. Mm-hmm. You forget. Mm-hmm. And so it's going to take you that long to get over the flu, longer to get over the flu. Mm-hmm. So you won't be able to return to work. Mm-hmm. And it's only because you can't afford the expensive medicine. So we have racism that way. Pain. In the ER, you come into the ER, and you have an ER doc who is under the belief that blacks can experience more pain than whites. They won't give you the pain medication, because if they give you pain medication, in their head they already automatically think that most blacks coming to the ER is already drug addicts. Okay. And so if they going to issue a pain med, a narcotic, then it's just exacerbating the addiction of the drug addict. And so those are the things that we as blacks have to overcome. And it's because we doesn't have enough black professionals in the medical profession that can...
That'd make a difference.
Right, yeah, because in our communities, like we have probably like 3% in our community is a black doctor. So we don't really get that much.
So we need some black doctors.
We need some black doctors.
We need black doctors. Okay, we're going to have to work on that as a community to get some black doctors.
Yeah.
Well, I mean, it's important. I mean, even in my walk, I mean, this was the whole reason why we started this show. This show actually came about because of my personal interaction in healthcare with my own health, with my own son's health, and the things that I encountered, and even being a healthcare professional still didn't prepare me for the things that I encountered. Because you think that if you work in healthcare that you know these things. Oh, well, you're going to go through this, you're going to go to the referring physician. You know the workflow process. What you don't know is how intricate that workflow process becomes when you become victim to the system. I'll give you an example. This actually happened to me recently, not me per se, but in my family. There was a, one of my family members actually was prescribed a medication by a dentist, and the medication caused an adverse event. The adverse event caused the person to have, psychoactive, behavior and, mental health behaviors that are, basically aligned with a schizophrenic, okay, which was totally, not characteristic of the person. It was obvious that this was a medication reaction, a drug allergy. However, the problem is this: the person goes into the hospital. The doctors are told this is a drug allergy. They're told what the drug is. They're told where the drug came from. They're told who administered the drug. They are aware that this is a drug allergy. And they take the patient and put them into a mental health facility because they're having psychosomatic, issues. They're actually psychotic issues and other types of mental health issues that are aligned with bipolar, schizophrenia, whatever the case may be. So, you take the patient and you put them in the mental health part of the hospital, and then now you've given them 3 or 4 different psychotropic drugs based on a drug reaction. You have now exacerbated this patient by giving them 4 or 5 psychotropic drugs, which are actually drugs intended for people who actually suffer from bipolar and schizophrenia and mental health diagnosis. Okay?
Yeah.
And then because of COVID, there is lack of interaction and care coordination between the hospital and the primary care. So when that patient gets discharged, the primary care physician has no knowledge that he's been put on 3 and 4 different meds that has nothing to do with why he went in there in the first place. And then when we rotated to go back for the primary care visit, which is the follow-up post-hospital, the primary care physician has no knowledge of the allergies or none of those things that took place because it was not communicated to him, which means that ultimately the primary care physician could have prescribed the same medication, not knowing, for that patient for, let's say, another issue that they had, which is why they went to the dentist. They could have went and just said, okay, you're out of your meds. Let me go ahead and give you what the dentist gave you. Not knowing, because that care was not communicated and coordinated properly. So you took a person who had a drug allergy and you've now walked them through the whole mental health system. This is documented in the EMR. This is documented in their records. This is documented through each care system. And when you are making these documentations, they're permanent. It's permanent in your record. So now when you go to another doctor, they're saying, oh, you've had mental health illness, you've been treated for all of these things, and you've never even had mental health illness. You were treated as a mental health patient when you experienced a drug adverse event. And that is very serious because we have seen the interaction of healthcare professionals and how they have just utilized and abused the healthcare system because of COVID-19 in all various types of ways. Billing for every single thing that a patient comes in for is COVID-19. We know of a patient who actually died in a car accident. It was diagnosed as a COVID-19 incident. How is that possible? It's a virus. The virus didn't cause the accident. Just ridiculous things of that nature.
Normally, if blacks go into the ER and they're suffering from severe depression or fatigue, they pretty much are diagnosed as schizophrenic, and then they're sent to mental health, and it because it's a misdiagnosis, it gets mistreated, and so it's pretty common, and that's the racism in the mental health profession there. Yeah, but that happens a lot.
Yeah, the assumption is if you come in with something, you must be a drug addict. I mean, like, it is literally assumed from the door.
Yeah, and that's just miseducation of the medical profession, and when you get down to the root cause of the medical profession and discrimination and racism, it's that, like in medical school, you're pretty much taught how to treat Europeans. Okay, and so your African Americans is really not considered. There's some diseases like sickle cell anemia that are more prevalent in our race, but there is not very much research done, and because in our community we don't have the endowments for research to research certain things that we should do. So a lot of things that we do as physicians is we prescribe medications that we know that works for the Europeans and not really for African Americans. Like recently, within the last 10 to 14 years, they discovered that the way that we treated blacks with high blood pressure, we were treating them the same way that we treated white people with for hypertension. And we were using it was like a one pill treatment as opposed to currently now it's either a two pill treatment or a 3-pill treatment. And it wasn't until quite a few African Americans had passed away off of high blood pressure that they decided to try these additional medical treatments in order to. Now, what we don't know is even though we are using we might use what's called an ACE inhibitor, and we might use a channel blocker, okay, and ARB. We don't really know what the effect that is having on us as African Americans, because those are pills that we use for in the white community. So we're actually taking those pills and saying, well, let's give them this, let's give them that.
One size
work,
fits all.
and let's give them that, with not very much research being done on it.
Okay.
And so that's what happens in healthcare with because our bodies are different in some aspects.
Absolutely.
Some things we can handle more than they can. Some things they can handle more than us. Salt, for instance, the salt content. Our bodies maintain a high salt content, and it's genetic. And not very many studies have been done on salt content, except that we know salt causes high blood pressure. But there's other advantages of salt. Salt and potassium is the thing that actually is almost like the beginning of life, is to make the cells work.
Okay.
And as salt enters the cell, potassium leaves the cell. And so if you have more salt in your bloodstream, then you have potassium that could cause some issues.
Okay.
Right? And so we ended up having hypokalemia,
Okay.
which is
Hardened.
more potassium in our bodies. So those are things we just need to have medical research. If once we get to a point where we are maybe economically equal, then we're able to put more of our own funds in the research.
Economically equal?
Uh-huh.
We should wait for this?
Yeah, if we ever get to that.
Okay, because you have to live to get there.
What they call
we already
have
have disparate health care, so we have to
or what they call reparations, if you ever get those. But I believe that's what it's going to take. Because even if we get more African Americans into the medical school, they're still going to be taught.
They're going to be taught European way of
Exactly, yeah.
Yeah, of basically treating on patients. So basically, we're just spinning our wheels, going to the doctors because, I mean, you're really not treating me as a wholesome person. You're treating me based off of, the masses of the Europeans and so when I have a diagnosis, it may be, for example, I actually did have a diagnosis. I had a teratoma tumor in my right thoracic cavity. And based on, I guess, the makeup of it, it originated from some region, so it was considered rare, Okay.
So we're pretty much on the margins of society, and We have it better here in the United States than we do in some of the developing countries. Or even when you're in Africa, you find that the roads are not built for the people who live there.
Live there.
The roads are built to take minerals out of there.
Exactly.
You know, and so in America, the roads are not built for you and me. The roads are built in order for commerce. We just happen to come along and we live on the road.
Right.
But if we didn't live on the road,
There's another issue too that is pretty concerning, and that is looking at maternal health and maternal and fetal health. Actually, here in Atlanta, Georgia, it seems that we have a very high rate of mismanagement around pregnant women. Why is that? And we're like number one. What is it about Georgia and the physicians we have? Is it because we're in the dirty South, or what is it? I mean, that's what I heard them call it. But is that we're in the dirty South? I mean, why is it that in Atlanta we are suffering, or women who have babies are primary in terms of fetal death or exacerbated conditions, or they're just totally mismanaged? Why is that?
well, it's mismanaged health care, again, because
Why is Atlanta like at the top? Like not New York or California, but Atlanta. I mean, this is the South. So
you
that
mean
just
the
seems-
Georgia or the city?
in Georgia.
In Georgia, okay.
Well, I
Well,
say Atlanta because,
yeah.
of course, you're dealing with, with the city, whatever. But I mean, if you look at, retrospectively, it has typically been Georgia as a
Okay,
whole.
yeah. And it's because you don't have the prenatal care. I mean, the prenatal care is there, but then being able to get people into their physician to get the care is a whole different ball of wax. The infant mortality rate is for black women 4 times as high as white women. And so that's because of the discrepancy in socioeconomics, education. We are just not educating our communities. We're not providing the care that they really need. We don't have the doctors that they need. And we don't have the, I once said the desire, but it's like how many clinics are in our community, and so
Well, a
if
lot
we
of
go
people have
travel to the
lost
clinic,
insurance due to COVID-19, which brings me to that. And so a lot of people may think they can't afford health care because they've lost insurance. So a lot of organizations, a lot of clinics that I go to, it's like the first thing you're going to get is, do you have insurance? That's the first thing. If you don't, then of course they're going to go to the next thing. How are you going to be able to pay for your care? So I think another thing too is helping people find a good doctor. How can you help a person find a good doctor? How does a person know? And we just want to wrap it up with that on how can a person find a good doctor? What characteristics should they look for? If we are, well, I leave that alone. But how do you find a good doctor? If I receive insurance, if I receive a job, the first thing they're going to give me is an insurance package of approved doctors that are associated with an insurance company. And so you're basically going to choose Dr. A, B, C, D, or you're going to look them up. You're going to try to find out what information you can based on the information that the insurance company shared with the public. But that's just not enough. How do you know for sure that you have a good doctor? Like what characteristics should a person look for to know that this person is engaged? And the reason I say that is, and I want to close with this, is because I had a compromised pap smear a couple of years ago, and it probably was because I was going through menopause, and so the doctor recommended to me to follow up with another pap smear. It turns out that the doctor that I wanted to follow up with was not available, and I ended up going to a white doctor that I'd never seen before. This man literally refused to give me a pap smear. And so I just get really black. I got really black, and I said, "You're going to give me a pap smear today." And because it was important for me to get the results, to see my threshold where I was at the time. He didn't feel that was, he didn't feel that was, important. But it was important for me because I was instructed by another physician to follow up, and those were the instructions given to me. And he just said I would have to come back another time, or, I would have to schedule it with another doctor or even a female on his staff. And when he said schedule it with a female, to me, he appeared to be blatantly refusing to give me a pap smear. And I literally just had to act really black. You know how that is. shaking their head and doing all that, for him to say, look, okay, we're going to go ahead and do it. And I'm sure he did it painfully, but, you know, how do you know you have a good doctor? I went to him, I read all these accolades about him. He was very rude. He was very disrespectful, and he refused to do a procedure that needed to be done.
Well, the first thing you want to do, if you can, is you want to find someone who looks like you. Because someone that looks like you is going to be someone who you're going to represent their sister, or, you know, they feel some kind of affinity, commonality to who you are. It happens. It's pretty normal for a physician to feel affinity to someone who looks like him, because he reminds you of my Uncle John or my uncle or my grandmama. And it's through all races. I've seen it. Whites give more attention to white patients. Black patients give more attention to black patients.
Do you think that there's some doctors who are black who actually do not like treating black patients? Because I've seen, and I've worked in healthcare for over 30 years, I've seen doctors who are pretty much abusive. Now, when I say abusive, I mean in terms of, you know, let's say someone shows up, you know, they're not of, you know, high class, and they come there and they have diabetes, and they walk away with 10 and 15 medicines. But even when they're communicating their care, calling the office, how they're treated differently as opposed to other people who are, you know.
Yeah, I mean, if you grew up in a community or society where you didn't experience any poverty, if you grew up middle class or upper class, and you never really dealt with people in the inner city, then you don't really know how people in the inner city behave. So people in the inner city comes into the ER or into your clinic, and sometimes they rambunctious and they don't speak properly, and you have a tendency to look down upon them. So you basically want to, you know, trying to find a doctor who's conscious of that and understands that.
Or has a diverse case mix.
Yeah, well, not so much a diverse case mix, because it's just in the healthcare professions in the ER, the people from the inner city, no one wants to treat them. They don't want to work with them. They're just too difficult.
Okay.
They won't take the medications. They won't follow instructions. They tell me what they want to do. And then the other thing is when you have to find a doctor you can talk to. Doctors like patients who take responsibility for their health. When you come in and you want to create a partnership with your doctor, and you're able to tell him what you want, and you know, you share. And you say, I got hypertension, and if he said, what is hypertension, and you can't tell him what hypertension is, it's like it's a waste of his time to try to explain it to you. So then he just give you some pills, and then you go away, and you come back with headaches a couple of weeks later because the pills didn't work.
I noticed that you all have really good prices for the services that you provide. Could you please tell everyone in the public what the name of your practice is, where they can come and, you know, get treatment if they so desire? Because, of course, again, like I stated, there are a lot of people who feel that they can't afford health care, and even just to get a basic physical would be very helpful in, you know, baselining your own self-care.
Well, I work with Murray Health and Wellness Clinic. There is 3 clinics, one in Norcross, one in Austell, and one in South Fulton on Cascade Road. And we're opening up a 4th one.
You said it's called Murray's Clinic?
Murray's Wellness, Health and Wellness Clinic.
Okay, Murray's Health and Wellness Clinic, you guys. So any of you guys that's out there that don't have insurance, if you're looking for a physical, if you're looking for some affordable care, if you're looking for, you know, to find a doctor, or just to get a doctor that can provide you with some basic treatment until you find a doctor, you know, go to Dr. Dillard. Say it one more time, please.
Murray Health and Wellness Clinic. There's 3 clinics in the Atlanta metro area, one in Norcross, one in Austell, and one in South Fulton, right off of Cascade Road in Highway 285.
Okay. All right. Well, we certainly do appreciate that. Thank you so much for being our first esteemed guest, Dr. Dillard, for believing in our vision as a melanated community. I want to thank everybody for listening. Of course, please look forward to joining us on many more sessions to come. We'll be interviewing Dr. Canary Fuller next week around the stigma on mental health. If you like our vibe, please subscribe. You can reach out to us on Instagram on It's Your World, Manifest TV, Status Network. We are on Twitter, Instagram. You can find us anywhere. We want to thank the folks in the community who have been supporting us and who will continue to support us as we bring worthy news to the community and find some solutions and information that is beneficial to us to bring us to a higher perspective. So we want to thank you again for joining It's Your World, and we advise you to follow us to keep up on all the new stuff and all the new news and all the goodies to, keep us taking care of ourselves and keep us informed. We want to thank Status Network for believing in our vision, for allowing us to host on their platform. And to everyone else, we appreciate you. Thank you so much for your time, and we look forward to seeing you again on It's Your World here on Status Network in Atlanta, Georgia.
Thank you for having me.
Thank you for having me.